if you want to distill psychiatry and really focus clinical examination from a symptom perspective, think about PACES. You want to call it space, you could call it space. Perception. Perception includes your internal stimuli, external stimuli, the integration of that. And this involves a part of the brain known as insula. We'll see the salience network. This part is involved in pain disorders as well. So perception, we often think of hallucinations, we often think about delusions, but it also involves pain perceptions, somatic perceptions, somatization, the whole lot. We will also see this part of the brain involved in functional neurological disorders. The next one is activity. Here we have striatum. So this we talked about. Activity can be lowered or activated. Then we have cognition, the prefrontal cortex. Emotion, reward, so change in reward sensitivity, and sleep. If you examine these pathways or these symptoms in detail, you've got a pretty broad understanding of the individual and what to target. The symptom I mentioned, but sleep was transdiagnostic across everything, right? So sleep is your best transdiagnostic marker. And how do I use sleep? For me, the best way of knowing if my treatment's working or not is to evaluate sleep. Because sleep doesn't lie. Are you able to fall asleep? Are they having racing thoughts, or can they calm down the arousal pathways? And that requires a good prefrontal cortex functioning. Do they enter into the appropriate phases of sleep? What I'm interested in is whether vivid dreams and nightmares are present. Because if they are, and they're very vivid, that tells me REM activation's present. And in REM sleep, noradrenaline needs to be silenced. So if it's present, I know exactly how to target it. Do this tomorrow. The next phase, they need to enter into adequate non-REM sleep, right? And in REM sleep, where you'll have other disorders present, obstructive sleep apnea, etc., we need to look at. And then finally, I need to look at non-REM and their waking. If they're waking up early morning wakening, that is a telltale clue towards agitation. Agitation is different from hyperarousal, which is different from anxiety. And all three require a different strategy. So this is why sleep, if sleep's good, it's telling you your treatment's working from a psychopharmacological and psychological point of view. So this is a very, very helpful paradigm.